Hello, everyone. Thank you for joining me today. My name is Kara Prawley. I'm a licensed addictions counselor and social worker here in the state of Kansas. I am also part of the MSW grad school program at Wichita State University, and soon will have my LMSW license in Kansas. And today I want to share with you about maternal recovery and perinatal child welfare, and really looks at some alternatives to immediate removal for women with substance use disorder. So before I begin, I want you to take a moment and think about something. When an infant is removed from the mom due to substance use disorder, what do you think happens next for that mother? 12 years ago, I was that mother. I was addicted to substances. I'd wrecked my life. I didn't know how to get help. I was scared. And my son was taken from me shortly after birth while I was still at the hospital. It was one of the hardest things I've ever gone through. And I've spent the last 12 years thinking about how that situation could have been different if I'd been given support, how I was treated, and the long-term effects of that experience. Mostly I've thought about how I could help other women who are going through the same situations to have a better chance at recovery with their children. Today I'm a social worker, I'm a counselor, I dedicate my life to helping others, and now I understand this situation through both a professional and clinical lens. As social workers, we really have an important part to play in these decisions, and the way that we respond can shape what happens next for both the mother and the child. So today we'll focus on 3 areas. The first one, understanding how infant removal really impacts maternal recovery and the mental health for those mothers. We'll look at how trauma and attachment theory help us understand that impact. And then we'll explore what alternatives are available that support both safety and recovery. So why does this matter? I've told you why it matters to me, but it matters because about 20 to 25% of removals involve infants, and infants under the age of 1 have the highest rate of entry into the foster care system. We also know that parental substance use is a major contributing factor. Our data will show that. And many cases involve CPS contact beginning at birth. So before I go any further, how many of you have known a woman who has had a newborn or child removed? Yeah, so a lot of us know someone that this has happened to or have heard of it before. Some of us have experienced it, and if you haven't, to be a mother and have your child removed is a really tough situation. So let's look at some data for the state of Kansas. This is between July 2024 and June 2025. So we see that year that 2,449 children were removed from homes and away from their parents. Of that number, 281 of these children were removed related to some sort of substance use. 63 of those were infants that tested positive at birth and were removed. Of this number, during this year, 1,923 of these children had adoption identified as their permanency goal instead of reunification. And that same year, 635 children were adopted and they did not return home to their parents. So when we look at these numbers all together, it really shows that a significant number of children don't return home after they're removed. And that really highlights how important early decisions are, especially at birth. So again, 635 children in 1 year were adopted and didn't return home to their parents. We're also seeing an increase in children being removed from homes. Well, there are not enough foster homes available to meet that need. So this has become problematic. I know a big issue is how do we find more foster homes? The system is overridden with children with no place to go. And this is not only a family level issue, it's a system level challenge. So, removal is often used as a safety response. Historically, there's been a focus on separation of mom and child in order to protect the infant, which is clearly important. But what we're seeing is this approach may also create unintended consequences or harm for mothers, especially when they don't have much support. Women with substance use disorder, particularly mothers, experience stigma in multiple ways. So the public stigmatizes women by calling them bad mothers because they use substances or can't stop when they're pregnant. Self-stigma shows up when the women feel a lot of shame and hopelessness within themselves. Provider stigma shows up as judgment in systems where the women go to receive care. And structural stigma appears in policies that really prioritize punishment over support. So we're not just talking about one type of stigma, we're really looking at all different types of stigma impacting mothers at the same time. So we know that addiction is recognized as a chronic disease. It affects brain function, behavior, and decision making. So this isn't just a matter of choice that the moms choose to continue using substances. It's much more than that. Because of this stigma, the moms often don't feel safe being honest about what they're going through or experiencing to get the help that they need. And that often starts long before the child is born. So during pregnancy, this is how I felt also. Many women are afraid to disclose that they're using substances or that they need help because they're afraid that that will lead to child protective services being involved and the infant being removed. So instead of asking for help, they may avoid care, minimize their use, or not disclose this information at all. And what that does is that fear becomes a major barrier to early intervention. We need systems of care and providers who are really giving that unconditional support and encouragement to help these women. So removal is often experienced as a traumatic event. Many women already have a significant history of trauma. So this removal can re-traumatize or re-trigger those experiences. And this will lead to grief, shame, emotional distress, and disruption of early bonding for mom and baby. There are also serious mental health effects. Research shows that there's an increased risk of depression, anxiety, and psychological distress. We also find in research that mothers are significantly more likely to attempt or complete suicide after removal. We know that loss of a child, especially an infant, is experienced similarly to grief after death, but more complicated because the child's still alive. And for many mothers, this becomes a very dark period. The postpartum period is really a critical turning point for these moms. So some mothers may already be in recovery while others are still actively using substances and don't know how to access help. When a baby is removed for a mom who's in recovery, it disrupts her stability, her routines, and her connection, and can remove a major motivator for change. So picture this. A mother has just given birth. She's in the hospital, physically recovering, emotionally vulnerable. And instead of leaving with her baby, she's being told her child is being removed, or the child's removed without them even telling her. How might she feel in that moment as a mom? So for a mother already overwhelmed by addiction, shame, or trauma, that loss can really deepen her feelings of hopelessness. So when we say loss of purpose and hope impacts recovery outcomes, This is what this looks like. It may not just interrupt recovery, it may prevent recovery from beginning, because when that baby's removed from that mom and she loses all hope, oftentimes she spirals. So, trauma theory helps explain how removal can trigger stress responses and emotional dysregulation. Like I said earlier, many women already have trauma histories, and removal can reactivate those experiences. This can increase distress, intensify feelings of shame and loss, and make it difficult for moms to regulate their emotions or engage in support. Attachment theory highlights how critical early bonding is between a mother and an infant. We know the postpartum period is a key, very important time for developing a secure attachment, which leads to safety and trust for that baby. When separation occurs during this time, it disrupts the bonding process. So for the mom, it can affect her sense of identity, connection, and confidence in her role as a mother. And for the infant, early separation can interfere with the development of secure attachment. That's associated with long-term outcomes related to emotional regulation, relationships, and overall development. So these are not just short-term effects. These can influence, and they do influence, attachment patterns and functioning across the lifespan of the child. So when we look at all this together, the trauma, the mental health, and recovery piece, are we supporting the outcomes that we really hope to see? And more importantly, what does research suggest instead? So one place we can begin to shift is how we work with mothers in this system. Often, mothers are given a checklist to complete without a lot of care or compassion, but without support, those tasks can feel really overwhelming. So that what that can show up as in the system is looking like noncompliance, like moms aren't doing what they're supposed to be doing, but may actually reflect fear and lack of trust for those moms. They're in a system where their child has been taken and they're terrified. So without trust, mothers are less likely to be honest about what they need. And a more effective approach is collaboration. So ask the mother, what does she want for herself and her child? What are her goals? Talk to her about her fear, her lack of trust, and what she's been through. So mother-infant programs, they're shown to be effective, involving treatment retention and parenting outcomes. They're not just supportive approaches, they're evidence-based interventions. And picture that same mother as before, but instead of her child being removed, she's able to stay with that baby and get support and connection and help. How might she feel then? That difference between loss and hope can really change recovery outcomes. Family-centered approaches address housing, stability, and access to care. When these needs are met, engagement improves and outcomes are stronger. So when we look across the research, what we see is that the most effective approach is an integrated model of care. This means addressing substance use, mental health, trauma, and basic needs like housing and stability all at the same time, all under the same umbrella, and not in separate systems. In practice, this would look like a mother being able to access substance use treatment, therapy, parenting support, trauma-informed care, case management, and housing resources all in one place with providers working together as a team. She wouldn't be told to go here and here and here and have to come up with money that she doesn't have and figure everything out on her own. It would be collaborative. Instead of navigating multiple appointments, agencies, and expectations on her own, she would really be supported within a coordinated system that understands her full situation. This matters because recovery does not happen in isolation. And when you think about it, if a mom's trying to address her substance use, but is also dealing with untreated trauma, no place to live, or lack of support, it becomes much more difficult to engage in services and sustain progress. Research shows that when these services are coordinated and delivered together, outcomes improve across multiple areas: recovery, parenting, and long-term stability. Another critical component of this model, best practice is women with lived experience. So we know that women who have been through similar experiences and share that with the moms can reduce shame, build trust, and help mothers feel understood in ways that traditional systems often cannot and do not. They can also model what recovery looks like for the new moms and provide a sense of hope that change really is possible. This is what we mean by an integrated model, and research shows this is the most effective approach for supporting both mothers and their children. So we know that traditional approaches focus on separation, and therapeutic approaches focus on collaboration and support. This is not about gauging risk, compliance, and punishment, but about creating connection and accountability, about supporting both safety and recovery. In conclusion, removal is intended to protect children, but it can have serious impacts and cause harm. Research shows that safety and recovery can exist in one space. When mothers are given support, connection, care, and hope, the outcomes improve, and integrated trauma-informed approaches always lead to better outcomes. How we respond as individuals and as social workers really matters. And when we respond differently with love and care instead of judgment and shame, outcomes can and do change. So I want to leave you with this question when you're out there working with women, and think about what might change if before making life-altering decisions, you took the time to sit with the mother and really work to understand her story, her trauma, and her fears. Thank you. Included here are my references and my contact information. Please feel free to reach out, text me, email me for any questions you might have, or to learn how to better support women who are in this situation and recovering, because recovery is possible, and I am living proof of that. Thank you.